Hello everyone, now let us discuss about 2023 ICD 10cm coding guidelines for chapter 9, that is diseases of circulatory system, part 6. In the current session, we will be focusing about the guidelines regarding the acute myocardial infarction, AMI. Now, the guidelines for acute myocardial infarction are categorized into following types. The first one is the guidelines regarding type 1 ST elevation myocardial infarction, STEMI, and non-ST elevation myocardial infarction, NSTEMI, STEM and non-STEM. Next, guidelines regarding acute myocardial infarction unspecified. The next are acute myocardial infarction documented as non-transmural or subendocardial, but the site is provided. What must be coded there? The next is subsequent acute myocardial infarction. The codes regarding the subsequent acute myocardial infarction. Finally, other types of myocardial infarction. Now, first coming to type 1 ST elevation myocardial infarction and non-ST elevation myocardial infarction. The ICD 10cm codes for type 1. The ICD 10cm codes for type 1 acute myocardial infarction identify the site such as anterior lateral wall or true posterior wall, etc. The subcategories are I21.0 to I21.2 and the code I21.3 are used for the type 1 ST elevation myocardial infarction, type 1 STEM. Codes from the subcategory I20.0, I20.1 and I20.2 and I20.3 are used for the type 1 ST elevation myocardial infarction, whereas code I21.4 it is used for non-ST elevation myocardial infarction and is used for type 1 non-ST myocardial infarction and non-transmural MIs. Here you can see these codes are used for type 1 myocardial infarction. The first one is I21.0. It is further classifiable. That is why it is indicated by star mark. I21.0 deals with ST elevation myocardial infarction of anterior wall, STEMI of anterior wall, whereas I21.1 series, subseries or subcategory, deals with ST elevation myocardial infarction of inferior wall. Previously, when it is 0, it is anterior wall. Now it is inferior wall. Next is I21.2. It deals with ST elevation myocardial infarction involving other sites. And I21.3, this is a final code. It deals with ST elevation myocardial infarction of unspecified site. Whenever STEM is documented and site is not specified, you need to code I21.3. Next is I21.4. It deals with non-ST elevation myocardial infarction. And finally, I21.9. It deals with acute myocardial infarction, NOS, unspecified. Whenever the physician documents acute myocardial infarction and the type is not specified and ST elevation is also not specified, then you need to code I21.9. Now, coming to the scenarios. The first case is if a type 1 non-ST elevation myocardial infarction evolves to ST elevation myocardial infarction. ST elevation myocardial infarction is more severe when compared to non-ST elevation myocardial infarction. So, whenever a type 1 non-ST elevation myocardial infarction progresses or evolves to ST elevation myocardial infarction, in this case, you need to code ST elevation myocardial infarction code. Assign the ST elevation myocardial infarction. The second scenario, if a type 1 STEMI, ST elevation myocardial infarction converts to non-ST elevation myocardial infarction due to the thrombolytic therapy. Due to the drug therapy, the severity is reduced and type 1 ST elevation myocardial infarction converts to non-ST elevation myocardial infarction. Even in this case also, you need to still code ST elevation myocardial infarction. In either of the cases, you need to assign the ST elevation myocardial infarction code only. If non-ST gets converted to ST, then also you need to code ST elevation myocardial infraction. And if a type 1 ST elevation myocardial infraction gets converted to non-ST elevation myocardial infraction due to the thrombolytic therapy, even in this case also you need to code the ST elevation myocardial infraction codes only. The next scenarios are based on the time frame. We know that the encounters which address the myocardial infraction that is equal to or less than 4 weeks old. Remember this, the encounters which address the myocardial infraction that is equal to or less than 4 weeks old, including the transfer to another acute setting or a post-acute setting. The myocardial infraction meets the definition for other diagnosis. In this case, whenever it is less than or equal to 4 weeks old, then the codes from the category I-21 may be continued to report. You can report the codes from the category I-21 whenever the myocardial infraction is equal to or less than 4 weeks old. The second case, for the encounters after the 4-week time frame, and the patient is still receiving care related to the myocardial infraction. 4 weeks time frame has been elapsed and the patient is still receiving the care related to the myocardial infraction. In this case, appropriate aftercare code should be assigned rather than the code for category I-21. That is the second case. Coming to the third case, for old or healed myocardial infraction not requiring further care, the code I-25.2, old myocardial infraction, may be assigned. Now here are the various other codes for myocardial infraction. I-21.3 is ST elevation myocardial infraction of unspecified site. And whenever the physician documents acute transmural myocardial infraction of unspecified site, even in this case also you need to code I-21.3. Transmural Q wave myocardial infraction NOS, type 1 ST elevation myocardial infraction of unspecified site. In all these cases, whenever the physician documents any of these terms, you need to code I-21.3. The next is I-21.4. It deals with non-ST elevation myocardial infraction or acute subendocardial myocardial infraction. Whenever the physician documents acute subendocardial myocardial infraction or non-Q wave myocardial infraction or non-transmural. Previously it is transmural, now it is non-transmural myocardial infraction and type 1 non-ST elevation myocardial infraction. In all these cases, you need to code I-21.4. And finally, for myocardial infraction NOS, acute myocardial infraction NOS, you need to code I-21.9, which is acute myocardial infraction unspecified. Now coming to acute myocardial infraction unspecified. The code I-21.9, as we have discussed earlier, acute myocardial infraction unspecified is the default for the unspecified acute myocardial infraction or unspecified type. For acute myocardial infraction NOS and also for the unspecified type, the default code is I-21.9. And if only type 1 STEMI, that is only type 1 ST elevation myocardial infraction or transmural myocardial infraction without site is documented, then you need to code I-21.3. For only type 1 ST elevation myocardial infraction or transmural myocardial infraction without the site documented, the unspecified site, the code is I-21.3 ST elevation myocardial infraction of unspecified site. That is the NOS for type 1 STEMI or transmural myocardial infraction. Now coming to the guideline or case where AMI is documented as non-transmural or subendocardial but the site is provided. If a acute myocardial infraction is documented as non-transmural or subendocardial but the site is provided, it is still coded as subendocardial acute myocardial infraction only. In simple words, we know that I-21.4 It is nothing but NOS for non-transmural myocardial infarction. That is, even though if the site is not provided, you need to quote I-21.4. According to the guideline, even if the site is provided also, still it must be coded as subendocardial myocardial infarction only. If the site is provided, whether the site is provided or not, whenever the physician documents AMI, acute myocardial infarction, as non-transmural or subendocardial, the default code is I-21.4. Now coming to the guidelines regarding the subsequent acute myocardial infarction. A code from category I-22. I-22 subsequent ST elevation and non-ST elevation. For STEM and non-STEM, the subsequent category is I-22. It is only for type 1 or unspecified. That is important. A code from category I-22, which is nothing but subsequent ST elevation and non-ST elevation myocardial infarction, is to be used when a patient who has suffered a type 1 or unspecified AMI. Type 1 or unspecified. For type 1 or unspecified AMI and has a new acute myocardial infarction within the 4 weeks time frame of the initial acute myocardial infarction. When a patient who has suffered a type 1 or unspecified AMI and has a new acute myocardial infarction within the 4 weeks time frame of the initial AMI, then you need to code I-22 series. And the code from category I-22 must be used in conjunction from code from category I-21. That is, whenever we are coding the subsequent acute myocardial infarction, you need to code the specified initial myocardial infarction also. A code from the category I-22 must be used in conjunction with the code from category I-21. And the sequencing of I-22 and I-21 codes depends upon the circumstances of encounter. Depending upon the reason for visit, sequencing can be altered. It can be I-22 or I-21, depending upon the circumstances of the encounter. And one more important point is, do not assign code I-22. Do not assign the code I-22 for subsequent myocardial infarction other than type 1 or unspecified. I-22 must be assigned only for the subsequent myocardial infarctions of type 1 or unspecified. We should not code I-22 for other types. For the subsequent type 2 AMI, assign code I-21.A1. And for subsequent type 4 or type 5 AMI, assign the code I-21.A9. Now let us see the various codes of subsequent acute myocardial infarction. We are only discussing the subcategories. We are not discussing the direct codes. So first I-22.0. It deals with subsequent ST elevation myocardial infarction of anterior wall. 0 deals with anterior wall. 4th digit 1 deals with inferior wall. That is common for initial and subsequent acute myocardial infarction type 1. I-22.0, it is further classifiable. It deals with subsequent ST elevation myocardial infarction of anterior wall. Whereas I-22.1, this is also further classifiable. It deals with subsequent ST elevation myocardial infarction of inferior wall. Next is I-22.2 series. It is also further expandable. It deals with subsequent non-ST elevation myocardial infarction. Subsequent non-ST elevation myocardial infarction is given by the code I-22.2. And I-22.8, it deals with subsequent ST elevation myocardial infarction of other sites. This is a final code. And I-22.9, it deals with subsequent ST elevation myocardial infarction of unspecified site, which is nothing but subsequent ST elevation myocardial infarction NOS. The next point is, if a subsequent myocardial infarction of one type occurs within 4 weeks of the myocardial infarction of different type. For example, first type 1 myocardial infarction has occurred and later on type 4 myocardial infarction has occurred. Here 2 different types of myocardial infarction have occurred within the 4 weeks time frame. then you need to assign the appropriate codes from the category I-21 to identify each type. In such case, whenever the type is different, you should not assign a code from I-22. I-22 must be assigned only if the code from the category I-22 should only be assigned if both the initial and subsequent myocardial infractions are type 1 or unspecified. This is important. The codes from the category I-22 should only be assigned if both the initial and subsequent myocardial infractions are type 1 or unspecified. When the types are different, do not assign the code from the category I-22. Here you can see the various subsequent acute myocardial infraction codes. For the initial and subsequent myocardial infractions of type 1 or unspecified, when the subsequent myocardial infraction is when both the initial and subsequent myocardial infractions are type 1 or unspecified. For subsequent myocardial infraction, you need to code I-22. For the initial, you need to code I-21. And I-21 and I-22 must be used in conjunction. And for subsequent type 2 acute myocardial infraction, the code is I-21.A1. For subsequent type 2 myocardial infraction, the code is I-21.A1. And for subsequent type 4 or type 5 AMI, the code is I-21.A9. Now coming to the next guideline, that is other types of myocardial infraction. The ICD 10CM provides codes for different types of myocardial infraction. The type 1 myocardial infractions are assigned to the codes from the categories I-21.0 to I-21.4 and I-21.9. And type 2 myocardial infraction, that is myocardial infraction due to demand ischemia or secondary to ischemic balance. We will make a separate video on different types of individual codes for different types of myocardial infraction. As of now, the type 2 myocardial infraction deals with myocardial infraction due to demand ischemia or secondary to ischemic balance. It must be assigned from the code category I-21.A1. Myocardial infraction type 2 with a code for underlying cause. And do not assign the code I-24.8. Other forms of acute ischemic heart disease for the demand ischemia. Do not assign the code I-24.8, that is other forms of acute ischemic heart disease for the demand ischemia. And sequencing of type 2 AMIs or the underlying cause depends upon the circumstance of admission. If the underlying cause is the reason for admission, that must be sequenced first. Or AMI is the reason for admission, that must be sequenced first. And when a type 2 AMI code is described as non-STEMI or STEMI, assign only the code I-21.A1. There is only one code for type 2, whether it is STEM or non-STEM, that is I-21.A1. And the codes I-21.01 to I-21.4 should only be assigned for type 1 AMIs or unspecified AMIs. They must be assigned only for type 1 AMIs or unspecified AMIs. And acute myocardial infractions type 3, type 4A, 4B, 4C and 5 are assigned to the code I-21.A9. The other types type 3, type 4A, 4B, 4C and 5 are assigned to the code I-21.A9, other myocardial infraction type. Along with them, the code also and code first note should be followed. Code also means you need to code also the related condition or any associated condition. Code first means first you need to code the underlying cause for that disease. So code also and code first note should also be followed related to the complications and for coding of the post-procedural myocardial infraction during or following the cardiac surgery. And additionally, you need to use additional note. Use additional code note provided at the category I-21 and 22, which indicates that following should be coded if applicable. Use additional note indicates nothing but whenever the following scenarios or conditions are co-present with the acute myocardial infarction or subsequent myocardial infarction, you need to quote these conditions also. They are exposure to environmental tobacco smoke given by the code Z77.22, history of tobacco dependence Z87.891, occupational exposure to environmental tobacco smoke Z57.31, and status post administration of TPA in a different facility within the last 24 hours prior to the admission for current facility, that is given by the code Z92.82, tobacco dependence, which is given by the subcategory F17, and tobacco use given by Z72.0, and presence of hypertension. Whenever hypertension is present along with AMI, you need to quote the respective hypertension codes also. Here you can see the schematic representation. This is a normal ECG. This is ST segment, PQRS, and here you can see ST elevation. The ST segment has been elevated. There is elevation from this point to here. There is an elevation from the baseline. It is indicated in the ECG by this ST elevation. STEMI is indicated like this. Examples of non-STEMI are, this is ST depression. So the normal is this line. Here you can see depression than the normal baseline. It is a type of non-STEMI. And next is T inversion. The T curve usually it is upward, but for some types of non-STEMI it will be inverted. So this is indicated by T curve inversion. This is also a type of non-STEMI. Now let us see an example here. The patient is a 40-year-old male. The patient is a 40-year-old male with a past medical history of significant hyperlipidemia and coronary artery disease, CAD, who presents with a chief complaint of chest pain. Reason for visit is chest pain. He states that chest pain started yesterday evening and it is intermittent and it comes and goes, and he reports associated shortness of breath and diaphoresis. The patient states that he has been nauseated and has had 3 episodes of vomiting since the last night. He denies any fever or chills, and the patient denies any history of prior heart attack or stroke. He states he has not had a recent surgery, trauma or abnormal bleeding such as blood in urine or stool or nosebleed. Coming to the social history, he denies alcohol and drug use and smokes 2 packs of cigarettes per day. He is a chronic everyday smoker and works as a banker and admits to being very sedentary. Coming to the family history, father and brother has coronary artery disease. So he has a family history of ischemic heart diseases and other diseases of circulatory system. And at the office, the EKG shows sinus rhythm at 132 beats per minute, acute ischemic changes noted in the inferior leads, ST elevation in leads 3 and AVF. ST elevation is seen in leads 3. Coming to the treatment options, heparin block twice, nasal cannula oxygen 3 liters per minute, aspirin 325 mg, nitroglycerin drip at 30 mg per mg is given. Continuous cardiac monitoring is advised. PTA 90-minute protocol has been initiated, and heparin IV 500 units bolus followed by 1000 units per hour is the treatment plan. Coming to the assessment, the physician assessed that acute transmural myocardial infarction. The patient has suffered from acute transmural myocardial infarction of inferior wall with a history of nicotine dependence and family history of CAD. So, the first code is I21.19. It deals with ST elevation myocardial infarction involving other coronary artery of inferior wall. Additionally, patient has nicotine dependence, that is given by F17.210, nicotine dependence, cigarettes, uncomplicated. And also family history of heart diseases, that is given by Z82.49, family history of ischemic heart disease and other diseases of circulatory system. Now let us discuss one more example. 81-year-old male retired professor presents for the follow-up visit after hospital admission for non-STEMI. He was discharged just 5 days ago and now he is coming for follow-up. Currently denies any chest pain, shortness of breath, able to walk without symptoms, and the past medical history indicates congestive heart failure with diastolic dysfunction and non-STEMI and CKD stage 2. So the first initial myocardial infarction occurred while the patient was on cruise about 3 weeks ago. That is within the 4 weeks time frame. Limited data indicates ECG findings included ST depression and rise in troponin. And the subsequent non-ST elevation myocardial infarction. Here the initial is also non-ST elevation myocardial infarction and subsequent is also non-ST elevation myocardial infarction. Same type. It occurred with a rise in cardiac biomarkers with no ST changes on EKG 7 days ago, and partially reversible inferior posterior wall defect by perfusion studies has been diagnosed, and the physician diagnosed the disease of vein graft to the RCA. And what are the codes? The first is, here he is coming for the follow-up of subsequent non-STEMI. So the first code is I22.2, subsequent non-ST elevation myocardial infarction, followed by I21.4, non-ST elevation myocardial infarction. Additionally, you can see use additional codes. Under these codes, you need to report hypertension whenever it is associated. Here the patient is having congestive heart failure with diastolic dysfunction and CKD. So I13.0, hypertensive heart and chronic kidney disease with heart failure and stage 1 to stage 4 CKD or unspecified CKD, followed by type of heart failure, that is diastolic dysfunction, CHF with diastolic dysfunction. So I50.30, unspecified diastolic heart failure, and finally N18.2 to indicate stage 2 CKD. These are the various codes for this scenario. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.